My name is Dr. Daniel Kantor. I am the president of the Florida Society of Neurology. Much like Dr. Florete, I was also faculty at the University of Florida in Shands, Jacksonville. I came here approximately 6 years ago to the great state of Florida. 3 years ago, I decided that more good could be done outside of a state-run institution. I mostly see migraine and other headaches, multiple sclerosis, and concussion. So a lot of concussion rules have changed, and that's for a whole nother time, but I chair the subcommittee on concussion for Florida high school athletics. We're going to talk about chronic daily headache. We've heard on the one side about opiate use and responsible opiate use. We've heard about neuromodulation. Now let's talk about people with a specific pain syndrome, and that's headache, and how that might be a little different, and how we might be able to use sometimes some of the medicines, very infrequently opiates, and we'll get to that, and then sometimes neuromodulation, as we've heard. So another way of talking about this. Can we go backwards? This does not go backwards. Sorry. Keep going. Okay, there's more to life than opiates. Some of you who are watching the Olympics have seen Maroney. This is how she looked when she won the silver, and there's actually throughout the internet, there's her next to different items where she's not impressed. And in this case, she's not impressed by opiates. My disclosures are none for this talk, but I do speak and do research and do consulting for almost everyone involved with MS and some involved in migraine pain as well. So when we're talking about headaches, there's really two classes. We talk about the primary headaches, we talk about the secondary headaches. Primary headaches are the kind of headaches you want to have, because secondary means that it's secondary to something, often something much more dangerous. But when we talk about primary, we talk about episodic, and then we talk about the chronic headaches. Chronic headaches are usually defined as 15 or more headaches per month. This does fade in and out, right? Can you guys, can we turn this on? How about this? Is it on now? Okay, let's take off, as much as I love lavalier, let's take off the lavalier microphone. So, what is chronic daily headache? So when we're talking about chronic daily headache, what we want to think about is that this is a headache, doesn't have to be daily. It's defined as more than 15 headache days per month. This is one of the largest public health problems we have in the United States. 3 to 5% of the population in the United States and across the world really suffers from chronic daily headache. When we're talking about chronic daily headache, we have chronic tension type headaches, and we also have chronic migraines, sometimes called transformed migraines, that you can see as well. There have been lots of different terms. I trained at Jefferson under Steven Silberstein, and you'll see his name littered throughout here. He's the former president of the American Headache Society. But you may have heard terms such as transformed migraine. There is something else called a new daily persistent headache, and that's when from the onset you start to have headaches that are going to be daily in nature. And then we talk about hemicrania continua as well. So what are the risk factors for chronic daily headache? Not everyone develops them, but people who are more likely are people who are women rather than men. Obesity is a risk factor, and one of the biggest risk factors for having chronic daily headache is, in fact, to have medication overuse. Medication overuse does not happen just from opiates. It happens often from the combination medicines, and since moving to Florida, I've learned all about BC powders and Goody powders and all these other powders that are there in place to keep headache specialists in business. Without them, we would have much less medication overuse headache. So like I talked about chronic daily headache being from transformed migraine all the way to something called hemicrania continua, and of course medication overuse headaches as well. So what are transformed migraines? Transformed migraines are people who start out with episodic migraines. So they start out with this specific type of headache. And migraines don't have to be unilateral. They don't have to be throbbing. They don't have to be moderate to severe. But what we do is it's almost like one of these Chinese menus where you have to choose a certain amount from here and a certain amount from there. So people are more often going to be that throbbing than non-throbbing. They're more often going to be moderate severe than be mild. They're more often going to have associated features. And one of the features of migraine really is that you have the associated features that happen with them. So when you look at different ways that different people have studied transform migraine, they really talk about the episodic migraines, and then they talk about those episodic migraines going ahead and turning into a transform migraine. The moment you turn into a chronic daily headache or a transform migraine, you are not always having migrainous headaches. So if somebody who has a headache that's every day or 20 times a month, it doesn't mean that every headache is that throbbing, severe headache. Some of them might be milder, some of them will feel duller, but that person may still have chronic migraine that's going on. Now, it used to be this was all terminology. Now we're starting to have medications that are specifically approved not for just the prevention of episodic migraine, but also for chronic migraine as well. Chronic daily headaches can develop from the medication overuse, and there are going to be two different types of people with a history of medication overuse and the people who aren't. Fortunately, some of the medicines, and we'll get to them including toxins, seem to work with both types of headache. So as I said, when you look at the International Headache Society classification, what you see is that you have to have that on greater than 8 days a month, you're going to have these types of headache. Now, that means that the other times, the 7 or greater, don't have to be migrainous types, but you do have to have some migrainous types of headaches. And those are those same qualities that we talked about, the pulsing nature versus the moderate to severe nature. With all headache definitions, you have to rule out other potential causes, and you have to rule out really the secondary causes, which are going to be the bleeds in the brain, which are going to be the brain tumors, which are going to be if somebody has giant cell arteritis or temporal arteritis. All of these may happen. There's an easy way of thinking about chronic migraine versus chronic tension type headache. The chronic tension type headache has the same rules as the migraine, except the underlying headache is not a migraine, it's a tension headache. And it's easy to think about tension headaches versus migraine headaches, that in general, tension headaches are milder than migraines. In general, they're bilateral. In general, they're going to be dull and not these pounding, and they should not have the associated features. So when you look down there to section D to line 1, it says less or equal to 1 of photophobia, phonophobia, or mild nausea. So you could have some mild nausea. That doesn't make you go to a migraine. You could still be part of tension type headache. So like I said, when you talk about chronic migraine, you are going to be talking about a low-grade daily to near-daily headache with migrainous, as opposed to when you talk about a chronic tension type headache, which is going to be the same idea, but is going to be without the migraine features. New daily persistent headache. New daily persistent headache is not equivalent to chronic daily headache. There is a form of it. It's not the same as chronic migraine, not the same as chronic tension type headache. This is when the person does not start with the history and transform into a daily or near daily headache, but when the person starts from the beginning. Of course, this is going to be alarming at first. We're going to be scared. We're going to say, well, this person just had their first headache and it was the worst of their life. Right? You know that in medical school you always think about subarachnoid hemorrhage and aneurysm bleeds as the worst headache. There always has to be one headache that's the worst headache of your life, but that is just really a red flag for you. So new daily persistent headache, you really have to make sure that what you're not talking about is that you're not talking about a more severe or secondary cause of the headache. Hemicrania continua is important. It's rarer, but it's really responsive to indomethacin. And when it's responsive to the indomethacin, that means you give them indocin or indomethacin and they love you forever because you have done it. It's a little responsive to other non-steroidals, but for some reason they really seem to be indomethacin responsive. And by giving a person the trial of it, and some people would argue that every chronic migraine that you think is going to be chronic migraine, so every chronic daily headache, you should at least assume that maybe it's hemicrania, because hemicrania doesn't just mean one side of the head, because you also have hemicrania that changes sides, and you also have paroxysmal hemicrania, where it comes and goes. And interestingly, the root of the term migraine is actually from half the head. So migraine started, the French said hemicrane, 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 migraine. That's how the word migraine came. And yes, I was an English major at the University of Pennsylvania, and that's how they teach us etymology at Ivy League schools. The problem is, while this all sounds nice, a lot of times we as neurologists live in a bubble. We say, we don't like opiates, we're not prescribing them, we're not giving them to you, you're coming now to us, and we're not going to do that. But people often don't live in these lines of just having headaches, having migraines, versus having other somatic forms of pain. And often the medications they're taking for other parts of their pain can worsen their headaches as well. In multiple sclerosis, we often use beta interferons, which can cause flu-like symptoms. So some patients, 3 to 4 times a week, are getting a lot of naproxen, they're getting ibuprofen, they're getting acetaminophen, and they're having rebound headache or medication overuse headache just from that as well. So we know that for a long time there's been people that offer different types of cures and all these sorts of things, how they can do it. When you look back to ancient Egypt hieroglyphics, there sometimes is, in some of their images where they have drawings next to it, are going to be a person holding an alligator, it was probably a Nile crocodile, but a small one on their head. We think of that as like an ice pack, that was their form of headache treatment as well. Sometimes we know that there's been surgeries where they released the pressure from the head and those became the sorts of treatments. We try to really have randomized prospective clinical trials now, and that's how we try to do that. Medication overuse has also had a lot of terminology. But when we think about it, you may have heard of it as drug-induced, rebound headache. It's important that this is really not an addiction. This is different than the word addiction. It's even different than dependence. It's really that the headaches rebound. The patient shouldn't feel guilty about it. And they always say to me, I'm not overusing. I'm following the instructions on the bottle. And if there's any lawyers out there, what I do think we're going to see one day is a class action lawsuit against the makers of ibuprofen because it says keep taking around the clock. They do have that line which says consult your physician, but it says keep taking around the clock. Besides the 20,000 gastrointestinal bleeds and deaths we have a year, and besides the kidney failure we have every year, 3 to 5% of the American population has chronic daily headache, and medication overuse contributes to that. There are medicines that have more likelihood, and there are medicines that have less likelihood. Interestingly, opiates, butalbital, so the Furoset, the Furanols of the world, possibly sometimes with aspirin as well as with Tylenol, the other non-steroidals, and less likely are going to be a specific type of ergotamine, dihydroergotamine 45, and it's called, anyone know why it's got 45 at the end? DHE 45? From 1945, and that's where they came with it. And then neuroleptics also have less likelihood. Triptans, you'll notice, do have a likelihood, but when you take them away, they actually get better much faster than other people. Part of the reason why we don't see a lot of triptan overuse is because of third-party payers, where because triptans are expensive, people aren't getting a lot of their brand name Imitrex, Ralpax, Maxalt, and I could list all 8 of them if you really would like me to. So we like to think about the kinds of medicines they're using and why they cause it. I am on the Florida Medicaid, PNT, Pharmacy and Therapeutics. How many people here accept Medicaid, Florida Medicaid? So it's more than in a normal room of doctors and other practitioners. But we made a vote unanimously to remove Furoset and Furanol from the preferred drug list. This made me both a hero in some circles and an enemy in others. We revised it, and just so you know, the rules now are that the limit to Furosemide Furanol plus the Furosemide Furanol with codeine is 120 pills a year. Beyond that, patients, there's going to have to be a prior authorization, which will probably get approved, frankly, because they're cheap drugs, but we're really trying to do quantity limits, because when we talk about medication overuse, and we talk about opiates too, and we talk about abuse, there is the patient that's the problem, there's the insurance company if they pay for it, and then there's also the doctor. Without our prescriptions, people aren't doing that. And we do a very poor job in medicine of policing ourselves. And perhaps if we had done better, we wouldn't have police officers and law enforcement officers raiding our pain clinics and coming in after us. So the people who have the frequent headaches are going to start taking medicine. They're going to start taking the medicine. They're going to have the frequent headaches. It's going to become a vicious cycle. It's very hard to go ahead and to convince people to go ahead and to detox. One of the things I want us to lobby for in Tallahassee is that we talk about the drug problem. We talk about the opiate problem. I talk about medication overuse for chronic daily headache problem. We do not have detox centers. We do not have a lot of rehabilitation. We saw we have one of the exhibitors here who does some of that, but we don't have it throughout really the state of Florida, and that's important. It's important for us not to make our patients feel like they're the enemy. This is really not an addiction that the patient is having. So there's been lots of revised criteria for medication overuse. So the headache is going to be around for 15 or more days. It's going to be a regular overuse for more than 3 months of one or more of the acute medicines. And the headache has developed or gotten a lot worse during that time period. The problem is, a lot of times that time period, they're taking the medicine because their headaches are getting worse. So once again, sometimes it's difficult to make that definition. We've talked about the different kinds of looking at total exposure versus looking at specific medications. When you look at the opioids and the triptans, it's going to be defined as 10 days or greater a month. The other analgesics are really if you have it 15 days or a month that you're taking these medicines. And like I say, triptans are more likely to increase the migraine frequency as well. Medication overuse happens around the world. In the United States, sometimes we think that it happens more often here. People have more access to medicines. In parts of the Middle East, like in Lebanon, the doctors aren't using opiates for non-cancer pain. So it's much harder to have medication overuse from that. When you start thinking about how they're getting medication overuse, they're having it a lot more by combination analgesics is a lot more what we see as well. So it's going to depend, and just like I said, regionally, when I left Philadelphia and came here, suddenly we saw BC powders and Goody powders and all those things. I'm on the board of the Southern Headache Society. It's a regional headache collaborative of different physicians and their chair of education. And one of the things that came up was I was watching the Excedrin migraine commercials where they said the #1 recommended medication for headaches by neurologists. So I wrote to all these neurologists and I said, is this true? And I couldn't find anyone that said that's our #1 chosen medicine. So I'm not quite sure where they get that from. So even despite detox, the headache has been started in a cycle, and what we have to do is turn off that cycle of headache. We really do think about headache pain begetting headache pain, begetting headache pain. And even if you detox, it may not work. There's differences in different parts of the world in how you do that. And actually, when you look at it in Europe, they like to go ahead and detoxify. In America, it's harder to just take people off of medicine, and often we try to give some sort of bridge or rescue therapy. I do a lot of occipital nerve and other trigger point injections because I want to give the person some relief. Firstly, it helps them to believe in me. And I want them to believe in the power of their doctor working with them and how I'm taking them seriously and what we can do for them. And also, it's very difficult to tell someone to stop doing something when they're still having the headache that goes along. So obviously, migraine is going to be a lot more prevalent than chronic daily headache. But you start to see that men and women start to really become more similar than when you looked at just migraine where it was predominantly women. Chronic tension type headache is going to be less than chronic daily headache, because chronic daily headache includes chronic tension type headache as well as chronic migraine as well. Migraine, as much as we talk about it being an episodic disease, what we need to get across, and what we try with things like Headache on the Hill, we go to Washington, D.C., we try to advocate. When you look at the amount of funding the National Institutes of Health gives to everything, it's not really that much as we would like. But when you look at headache, it's really become smaller and smaller and smaller. And for a lot of times, even in the pain world, headache was kind of this like unlucky stepdaughter that was kind of seen as not having it. We have now in neurology more research on headache than we have on many of our other diseases that we take care of as well. So what can predict that you're going to go ahead and have that chronic daily headache? Well, some of these are really obvious predictors. If you start out with a lot of attacks at the beginning, you're more likely to spill over from 11 attacks to 16 attacks and become chronic daily headache than if you started out with 2 attacks or 2 migraines or 2 headaches a month. When we look at risk factors, like I said, we can look at risk factors that are modifiable. We can also talk about risk factors that are modifiable. Although I would argue obesity, which is really the plague of our nation right now, is one of these modifiable risk factors that's not quite so readily modifiable as well. Low education, we say, is not modifiable, but I wonder if we really can do a better job in this country. And yes, changing your sex, even changing your gender, does not actually change your sex, and sex is biologic, and so it doesn't have that effect as well. So what do we think happens in the pain that happens in headache and the pain that happens in chronic daily headache? We think about there being some peripheral nociceptive, and then what that's going to do is that's going to cause some central sensitization. We do think a lot about how occipital neuralgia contributes to migraines. And in fact, when you think about migraines, how many people here in the room have migraines, personally? Okay? So I'm keeping my hand raised because 70% of neurologists have migraines, 80% of headache specialists have migraines. And so I think we have that represented in the room. I think maybe we have 100% because I see some other neurologists, and we all have migraines. And so what happens there is some people have the exploding type, some people have the imploding type, and other people are going to have where the eyeball really feels like it's going to pop out. If any of you have seen the movie Pi, it's kind of one of these cult classics. Anybody seen Pi? I see so many audiences where no one's seen the movie Pi. It's really good. You should go home. It's just pi, like the symbol pi. And he goes and he drills into his head, not a treatment I recommend. And it's hard to tell, is he having cluster, is he having just regular migraines? But he's trying to really relieve that from happening. Remember, with people with migraines, they tend to go to a quiet room and they want to relax and not be around things. People with cluster headache actually want to try to move around to make the headaches get better. Then we get something called central sensitization, which is going to be also called cutaneous allodynia. So allodynia, al or all, dynia, painful. So what happens in allodynia is that it gets sensitive just when someone touches you. And it's very easy to ask patients about it. You can also test it. You just take a 4x4, or you take even just a regular cloth and you fold it up and you do this light brushing. That should not be painful or severely annoying. And if it is, then they have cutaneous allodynia. Usually that's a predictor that they're not going to respond right now to triptans or to other acute therapies, and you may need to go to other things. You may need to go to the neuroleptics. You may want to think more about the anti-inflammatories at that stage as well. I like to tell people I don't get cutaneous allodynia. I just have to take off my glasses, loosen my tie, and take off my watch. What I'm describing is that I have the central sensitization, or I have cutaneous allodynia. So when we're talking about the neurogenic inflammation, a lot of people know that they used to talk about vascular headaches. We've talked about how the vascular headache myth is over, and we're onto a whole new way of thinking about headaches. But if you think about it, we're still talking about the vasculature in a way. But now what we understand is that there's going to be almost like a pacemaker for the migraines. It's going to be in the trigeminal nucleus caudalis, so in the brainstem, And then what's going to happen is you're going to have a release of certain neuropeptides. And those neuropeptides are going to sensitize the nerves so that what you do is you start to get more pain. And then it becomes this vicious cycle really that is going to go on. So what we heard from Dr. Levy, we're really glad that he moved down here to Florida. What we heard from Dr. Levy earlier is that perhaps even stimulating in that area, you can have the effect. I mentioned I take care of MS a lot. My personal interest is the combination of migraine in multiple sclerosis patients. And sometimes we see that because of lesions in the brainstem. So a lesion of multiple sclerosis, so a plaque that's going to be in the periaqueductal, so the aqueduct that's going to be in the brainstem, periaqueductal gray matter, is actually possible that can lead even to migraine. So we know how important really the brainstem is when we think about the pathophysiology of the migraines. So you're going to have this neurogenic inflammation. What's going to happen is that you're going to have this pacemaker start. Then what you're going to do is you're going to have this release of the neuropeptides. There are some neuropeptides that we didn't used to talk about a lot, but now we understand are more and more involved. One of them in particular, calcitonin gene-related peptide, CGRP. Many of you may know that Merck was developing a drug which was a CGRP antagonist, also called telcagepant. Unfortunately, like many Merck drugs, it failed not because of efficacy, but because of liver function problems, and they stopped development. But we're hearing that other companies are starting up development on the next generation. And the basic idea is that we might have a medicine that works just as well as the triptans for aborting a headache, but instead of doing anything that might have to do with vasculature and may have concerns about people with hypertension or with history of heart attacks or older patients, it looks like it was going to be a lot safer. We did some of those trials here. I took part in them when I was at UF and Chance, Jacksonville. So all this talk of inflammation makes me, as somebody who also takes care of multiple sclerosis, think about migraine in certain ways. Think about migraine as perhaps being an inflammatory disease, but perhaps even being an autoimmune disease. I've been saying this now for 6 years, that somebody's going to show in the next 5 years that it's autoimmune, and so I guess I should have shown it because my 1 year is over. But we do see more and more data that we actually see release of certain cytokines, and we see interleukin upregulation. I do think there's going to be a subset of people with headaches who have migraine, and that migraine may be from an autoimmune inflammatory type of process. So we have these neurogenic inflammatory markers that are going to be released. And by being released, it can actually change in a way the way the sensory neurons are going to have their effect. So they're going to have their effect in the peripheral nervous system, and they're going to feed back into the central nervous system. This is similar to some of what we think happens in neuromodulation. We think through the neuromodulation that we just heard about, you could have stimulation in the periphery, and you could have an effect in the central nervous system. It's also why a lot of us do occipital nerve blocks as well as trigger point injections, because what we're trying to do is to have that numbing that goes on when we use lidocaine, bupivacaine, stop that headache cycle and really turn it off. Headache treatment, on the one side, you're going to have preventive. What can we do to prevent attacks? Then there's going to be abortive. What do you do when you have an attack? And then we're going to have rescue. So if you're using too much rescue therapy, if you have to go to the emergency room too much, you're using too much DHE45, so you're being hospitalized too much, all of these tell us that maybe the preventive is really not good enough. I think one of the best rescue therapies to shut down a chronic headache and to shut down a migraine is really going to be using trigger point injections. We don't add steroids into it. We did a study at Jefferson in Philadelphia that adding steroids just made more skin problems and didn't increase the efficacy. And so a lot of us just use 50% lidocaine, 50% bupivacaine, and you can go to the greater occipital nerve, you can go to the lesser occipital nerve, you can go different trigger points. Sometimes we choose, depending on where the headache is, the supratrochlear and the supraorbital. There are some people who do infratrochlear as well. I personally like to do the supraorbital and supratrochlear. in terms of when we're doing that. So in central sensitization, like I said, you have a non-toxic, just light touch, and it's going to feel painful as well. So once we have this allodynia, this makes treatment a lot harder. And so what we want to try to do is not get to that point. We want to try to stop the headache and stop the inflammatory release even before that happens. And that's why it's so important for patients to really understand that they know their headache best. So that's an empowering thing to tell a patient. But it also means that not every headache is a triptan headache. Not every headache is going to be an anti-inflammatory headache. Not everyone is going to be a neuroleptic headache. Some of them are going to be milder. Some of them you're going to try ice. But if you can predict that your headache is going to get really full-blown, you should treat it earlier rather than waiting till later to happen. So just like we have central sensitization, that cutaneous allodynia, in episodic migraine, we do know that a lot of people, in some studies greater than 50% of patients who have chronic daily headache are going to have that cutaneous allodynia, which means you're going around for half the month at least where you're not just having pain in your head, you're also having skin sensitivity. That can sometimes be misinterpreted as having fibromyalgia as well. And so it's very important in order to not place patients into perhaps stigmatizing diagnoses as well in order to go ahead and to treat it as well. We know that in pain modulation, opiate withdrawal can be a problem, and what's going to happen is it's going to enhance in some way the nociception, which is why when we're taking away opiates, which hopefully we can do, when we're taking them away, the person sometimes is going to have a worsening of their headaches. When we take away other medications, when we detox, we have to think about very specific issues. For instance, Furosemide, Furanol with the butalbital, we often need to hospitalize them. Otherwise, outpatient, we need to give them phenobarbital because it's a barbiturate. That whole idea of having a seizure when you withdraw from a medicine, that really started in our history of neurology with phenobarbital. So phenobarbital, barbiturates are the worst at that. You take away the medicine suddenly, and what you can do is have a rebound seizure really going on from that as well. So for an audience that writes a lot of opiates, it's not great to tell you that opioids a lot of the times are going to induce the pain and decrease the tolerance to the actual painful stimuli that we have. We do have emerging data, and some of it's controversial, but we have emerging data that opiates actually are going to increase apoptosis. So they're going to increase interneuron programmed cell death. Now, I use that for whatever or worse you want to think about the science. I use that when I'm talking to my patients in terms of justifying why I'm not giving them a Percocet for their headache. Because I tell them I'm in the business of neurology, keeping nerves alive, and I don't want to give you a medicine that could perhaps do that as well. We also can think about the NMDA. So when we think about NMDA receptors, they are going to prevent both presynaptically and postsynaptically the effect of glutamate, which we see as a neurotransmitter that can enhance pain. And this is one of the reasons why ketamine is used for pain and used for RSD or reflex sympathetic dystrophy or causalgia, however you want to call it, in Europe. Sometimes in the United States, although it's much harder to get it here. We also use other weaker NMDA receptor antagonists, such as memantine or Namenda. Some of us use it for migraine prophylaxis. And I will be presenting at the American Neurological Association in Boston in a couple of months data on a patient. This is just one case report of a patient that I've treated for over a year of relief, so probably outside the placebo effect, where she went from 20 years of chronic daily headache, and I started a medication which is a mixture of dextromethorphan and quinidine, brand name Nudexta. And the patient went ahead and now, instead of using 4 Excedrin a day, has used 2 in a month, 0 Percocet, and her headaches days are 0 or 1 out of 10. And so that response that we've had is prompting us to go ahead and to think about designing trials, investigator-initiated trials, where we look at it, I'm still debating whether it should be a chronic migraine trial, prophylaxis trial, versus episodic migraine. And part of the issue is that it's much harder to treat chronic migraine. So it would be great. On the other hand, there have been so many trials that have failed. And there's only one medication right now that is FDA approved for chronic migraines, and that's botulinum toxin type A on a botulinum toxin, so brand name Botox, as opposed to the other toxins, whereas Topamax, for instance, topiramate is not. So is chronic daily headache really a failure of us being able to turn off that pain cycle? And that might really be what's happening. The person's gotten revved up, but then normally you have a paroxysmal symptom. We have a lot of paroxysmal symptoms in neurology. We have seizures, they come and go. MS attacks come and go. You have migraines, come and go. You have TIAs, or transient ischemic attacks, unfortunately called mini strokes, that come and go, but sometimes that cycle is going to continue. And that's where we see the progressive nature of chronic daily headaches as well. We can actually see in brain imaging that there is going to be activation of parts of the brain stem as well when we're talking about people with migraine as well as with chronic migraine. And since you guys liked my other etymology question, my question is a couple of them. Anyone know why the medulla is called the medulla? So in the brain stem we have the midbrain, we have the pons, and we have the medulla. So medulla is like a bulb. It looks like a bulb, and the anatomists used to name everything after food or after plants. The midbrain is easy. It's in the middle of the brain, so it's called the midbrain. Then we have something called the pons. Anyone know why the pons is called the pons? Did I hear bridge? Yes, so the word pons from Latin comes from bridge. That's actually easier to understand. It's the bridge between the midbrain and the medulla. But then why is the pontiff called the pontiff? That's actually a more difficult question, whether the Pope is the bridge between man and God, or whether it's because in ancient Rome, the keepers of the bridge were actually the higher class. They were the richer type of people. And so that might be why. So when we're treating chronic daily headache, we're thinking about how to treat them. They're often very difficult. You don't have to do this alone. That's why there's people like us. There's neurologists. Then there are those of us that have gone even further and become board certified in headache medicine. You can go online and see where the headache specialists are in the area. We're accredited by the United Council of Neurological Subspecialties. It is not yet an ABPN fellowship or ABPN, so ACGME fellowship or American Board of Psychiatry and Neurology certification. So we want to make sure the person with chronic daily headache isn't having a headache because of a brain tumor, because of other reasons. We want to make sure that there aren't systemic reasons, and we actually have red flags. We have ways of thinking about red flags for headaches. One of the acronyms, and you can come to me afterwards in the break, and I'll talk to you about it, but one of them is called 2-SNOOP4. So 2 S's, then N, so neurological symptoms, and of course one of the O's is other, or opportunistic infections. People are going to be that, and then there's 4 P's that can go ahead and do that. So when you're talking about chronic daily headache, you want to exclude other reasons. You want to make sure which diagnosis subtype, because you might want to treat it with indomethacin if you think it may be hemicrania continua. Remember that you want to protect the gut if you're using indomethacin because it can be very caustic. And you want to make sure that the person has up to 2 weeks of the treatment so they don't just take one pill and say, oh, we didn't respond to it. So we talk about the different modalities of treatments. I talk about hot packs, we can have cold packs, ultrasound, TENS units. Often in my office, if somebody has a headache and they want it to go away, I will give them a TENS unit to use in the office, and I'll prescribe them one for afterwards. Unlike our colleagues in chiropractic medicine, I don't personally sell anything. I don't personally sell TENS units. So we talk about acute treatment. We talk about preventive treatment. We talk about what can happen when they're having the headache. So they're having the headache every day. So you don't treat it with a medicine every day, but they will have spikes. And that's the ones that you'll go ahead and treat. For preventive therapy, you're going to think about starting low, going very slowly. Remember, if someone's had a headache for 30 years, you don't have to hit them straight away really quickly because you may have them lose faith in you and you may cause side effects as well. And so often the benefit is going to be slow. It's not going to be dramatic, although I was impressed with this mixture of dextromethorphan, which is a weak NMDA receptor antagonist, and quinidine, which is the inactive ingredient, in how fast really the patient came, and she reported response to it as well. So for chronic tension type headache, we can think about medicines that may have an effect, that are probably effective. We're not having medicines that are FDA approved for these reasons. We think about tricyclics. Some of us are a little more cautious. We think about SSRIs and SNRIs. We can think about muscle relaxants sometimes, but all of these medicines are, of course, problems that go ahead with them. For transform migraine, topiramate or Topamax makes sense, although not in every trial, and we do know that botulinum toxin type A has met FDA approval, and we can go ahead with it. In terms of beta blockers, I personally don't love beta blockers. I've just seen too many people who have cognitive dysfunction due to beta blockers, and that makes me personally a little hesitant when I have other ways. The slides I put in your packets are going to go through the different medicines and kind of give you some of the data. We don't need to go ahead and talk about each study, but we've looked at tricyclics. We've looked at gabapentin. Gabapentin has never really shown great effect in a headache. The question about Lyrica or pregabalin, also not. There are newer formulations of gabapentin now. Some of our questions are whether maybe those will have a greater effect or not. Topiramate's a blockbuster in headache and in migraine. I think that if you don't ever start topiramate on a patient and they still have migraines, that may be cause for a person not going the full extent. I don't want to say negligence, but it may be the cause, even though I personally think that a lot of patients shouldn't be on topiramate because it can lead to what we term Dopamax instead of Topamax. And I often like to use medicines that are more complementary and alternative. Patients firstly like that idea. Nobody's probably exposed them to it. But there is data for magnesium, riboflavin, petadolax, which is butterbur, has great effect. And that's actually what I'll have for my go-to for children as well. I try to avoid medicines like Topamax for children. But then you think about other medicines, even coenzyme Q10, ginkgo biloba, all of these have been tested. Almost any medicine as it comes out, we test it for migraine and for headaches, and that's how we learn what is useful and what is not useful. We did do a trial here also in Jacksonville. We were part of the NIH, or the National Institute of Neurological Disabilities and Stroke, so a NINS trial, which looked at putting people on topiramate and adding propranolol versus topiramate plus placebo. That trial was stopped due to futility. The patients didn't do difference in either arm, and it was seen as a futile attempt at a trial. There was also a 23% dropout in the trial. Most often it was because their headaches actually responded to topiramate alone, which makes you wonder about the population we enrolled. And in fact, we know our population wasn't that chronic because we started out with a strict definition of 15 headache days per month. Then they said, well, we can't enroll enough patients, so we did it with 12 headache days a month. By the end of the trial, you could have 10 headache days a month, and you could be put into it. So you can tell we took more episodic patients than we did. Most of our trials are going to be double-blind, double placebo-controlled trials as well. And like we see with the topiramate in this example, and you have the slide, we look at 50% reduction of the patient days that they have the migraine. We also try to look at the severity of the headache and think about whether that has an effect or not. This is the top Chrome study. And what you look in these trials is you try to say, well, not just does it affect the headache, does it affect the other autonomic associated features. And then the other thing you're going to look at always is whether there's a difference between the responders who are medication overuse responders versus responders that won't. So you want to say, does medication overuse matter? And in fact, here medication overuse didn't matter. People responded just the same way, basically, that they responded if they had chronic daily headache for other reasons. There are a couple ways of understanding this. One of the ways of understanding this is that the medication overuse really didn't make a difference in terms of their headache pathophysiology in the first place. So a very controversial subject in headache is medication overuse. And here you see kind of more detail of that. So botulinum toxin. Botulinum toxin, what it does is it goes to the neuromuscular junction, and it's a toxin, and what it's going to do is it's going to weaken muscles. That's why it helps with cervical dystonia. That's why it helps with upper limb spasticity. That's why it helps with a lot of things. Most recently been FDA approved for bladder, for certain types of neurogenic bladder. But in migraine, we don't know why it works, because it's not clearly a musculature problem. And we actually don't go very deep. In the way we go with a 1/2-inch needle, a 30-gauge needle. We go to 35 sites. And we go to these sites throughout the brain and throughout the head and neck, and we'll go ahead and do them. So in these 31, I misspoke, now 35 sites that were used in the pivotal phase 3 trials. Now, unfortunately, the next few slides that you have in there are actually going to be, these are slides that you're going to see that are going to have the promotional slide of Botox. These are not unbranded slides. These slides are Allergan-specific slides. So they're just put in there because they do look at the 2 pivotal trials that led to FDA approval in terms of botulinum toxin, not for episodic migraine. You have to have chronic migraine. You have to have 15 or more headache days a month. You have to have tried other treatments. Now, that seems crazy to us when the insurer asks it because other treatments aren't FDA approved for it. But for better or worse, this is what the payers are asking us to do. So both trials were pretty similar. The drop in terms of the headache frequency wasn't as great as we may have wanted it to be. But what we do know is that you go from having more than 15 to having less than that number. If you start out with 30, you're not going to go down to 10. But if you start out with 15, you're going to go down. And so what we do know is that it's an effective, only FDA-approved way of treating people with chronic migraine. And all those slides are in your deck as well. So we started thinking about other treatments, and almost anything you can think about, we think about it. Maintenance opioids is a way people have been thinking about. I've thought about buprenorphine as well, as whether it makes sense. Our problem is we don't know what that's going to do to our patients as well, and it's not something that a lot of headache specialists in the United States tend to lead towards. So in Europe, they detox first and then do prevention. In America, if we're trying to detox, what we do is we're going to go ahead and we're going to do that prevention first. Our patients are more inpatient than the patients in Europe, and so we have to go ahead and do that. Sometimes we go ahead and we do inpatient hospitalizations. We don't have a great inpatient system here in Jacksonville. I've thought about it, and then when I went to the CEO of Memorial Hospital, I realized that basically I was volunteering to be on call every single night of the week. And I realized that as much as I like patients and I love headache patients and I love the difficult to treat patients, I wasn't sure if that made the most sense. So a lot of what we're doing because of insurers, because of other reasons, is we're doing a lot more medication treatment, infusion treatment on an outpatient basis, as opposed to the Raskin protocol of doing them Q8 hours with DHE. Sometimes we're doing them in the outpatient setting. We're doing them once and then 3 hours later with the medication, and you'll do that for 5 days. So there are other ways of going ahead. Some of us have done other infusions. We published on a series of patients that we used IV levetiracetam, so IV Kepron, and these patients had failed lots of other medicines, and they had a good response. We presented that at the American Headache Society a couple of years ago. People came up to me and said, how come some patients were getting 1 gram and other people were getting 500 milligrams? And the answer was that the 1 gram was what I was doing here, and the 500 milligrams was what Jefferson was doing at Thomas Jefferson University. If anyone knows Steve Silberstein, when he saw that I was doing 1 and they were only doing 500 milligrams, he said, that's it, I'm going up to 200 milligrams. And then I said, okay, I'm going up to 2.5. No, I didn't keep the bravado of going ahead and doing that. So outpatient infusion is usually going to be in an infusion center, but there are some things that can be infused at home as well. And when we're doing these treatments, what we're thinking about is pre-treating. We like to pre-treat a lot of times with Benadryl, so diphenhydramine. We're going to pre-treat with antiemetics. And one of the antiemetics, as well as other ones, Reglan, metoclopramide, has good headache effects. Compazine has good, prochlorperazine has good headache effects as well. And then Phenergan, which a lot of people use, but I think it's more abused by patients than the other medicines. I think people kind of crave Phenergan, and so I try to avoid it. Zofran does not have any anti-headache properties. So while it's great for nausea, it's very expensive, and it doesn't really have that as well. So we think about the outpatient where we're a little worried about withdrawal, and we might think about going ahead and putting them inpatient. What I've done here for your convenience, because I know there's no way you can see it up there, what I've done is I've put this into your slide deck, and you can kind of look at some protocols if you're starting to think about infusion treatments. Of course, you can always call me, and my contact information is at the end. And so sometimes we think about inpatient headache treatments. I always tried to get that off the ground when I was at Shands, but there wasn't a great consensus among the other physicians, and the residents balked at it. And if any of you guys know how medicine works nowadays, the residents are in charge. If the residents don't want it, it doesn't really happen. So what you can do is you can keep hydrating. You're going to go ahead and you're going to give the medicines. We like to think about, as I said, the prevention, the abortion of headaches. So we want to terminate them, especially when we're doing rescue treatment. And that's the DHE protocol that we talked about, the Raskin protocol, the modified Raskin protocol, where we treat them every 8 hours. We start out with 0.5 milligrams, then we go to 1 milligrams. You want to make sure that you pre-treat as well. Sometimes we use repetitive neuroleptics like Thorazine, sometimes even droperidol, although too many hospitals seem to be concerned about QTC. We did a study at Jefferson. The QTC never impacted the patient's health when it did get prolonged. We've even gone ahead and used IV lidocaine. I used to call our headache floor at Jefferson the iatrogenic floor, because we would do stuff like get a PICC line placed and it would go up instead of down. We seem to cause more problems. But in the headache world, we try almost everything. We don't just try beta blockers, we try ARBs. We try ACE inhibitors. We'll go ahead and do these sorts of things. IV lidocaine, it's hard to do because you have to put people into critical care monitoring for the first 15 minutes, and the nurses get mad, and then you put them into a monitored bed and do a lot of vitals. And so it looked like we had really good response, though, in terms of the IV lidocaine. What's the prognosis for chronic daily headache? Well, without treatment, the prognosis is poor. With treatment, hopefully, if we can get people out of that, we can get them back to work. We can reduce the cost to society. When we're looking at taking somebody off their medication, so this is when you get them off medication overuse, different medicines are going to have faster effects where you get back to normal. And like I said, triptans are going to be the most common, but actually, when you stop the triptans, you get back to the episodic form of headache as well. So you want to always think about prevention of headaches. You want to think about not just the medicines, you want to think about the multidisciplinary nature, and you also want to think about behavioral. Oftentimes you'll want to teach people how to have behavioral processes that are better. You don't want them just popping pills. We had a patient that was going to pop pills, so what we did is we wrote gabapentin, because we figured out of all pills, if they were going to pop them, they probably weren't going to overdose, and in fact they would gain so much weight that they would probably stop popping the pills as well. We wish we could have prescribed placebo, but unfortunately you can't still do that. And so we want to think about all these things, about how we really can help our patients. We know that acupuncture, there's some mixed data. There's also, for a lot of our patients, we use something called mindful meditation, as opposed to the of trying to get rid of all thoughts. In today's society, there's so much going on, and if we're quiet for a second, we can hear a little crinkling there, a little crinkling there. We see some humming from going on there. If you try to concentrate on everything, you almost distract yourself. So we refer our patients for mindful meditation, and there are a lot of books that go ahead in terms of that as well. I don't need to tell this audience how terrible pain is, but don't forget how terrible really headache pain is. I want to thank you guys for your attention. I want to thank you so much for inviting me.